upper GI of upper so upper GI bleeding. What then is upper GI bleeding? So this is bleeding in the gastrointestinal tract, proximal to the ligament of Treves. So the ligament of Treves is just located at the junction of the duodenum and jejunum. Then hematemesis is vomiting of blood, which may be fresh or like coffee ground material. Then melena is black tarry stone tutu bleeding from the upper gastrointestinal tract. So some of the causes of upper GI bleeding in Zambia are esophageal varices, PUD, those two being the commonest causes or top two causes of upper GI bleeding in our setup. However, we may also have esophagitis. We would have like a reflux esophagitis in the case of gastroesophageal reflux disease. We could equally have esophageal carcinoma, gastric carcinoma, mallory raised tears, and osteosarcoma. So some of the clinical features of upper GI bleeding are hematemesis, melena, abdominal pain, tachycardia, dizziness, fainting or loss of consciousness, fatigue, shortness of breath, and loss of appetite, to mention very few. To note, when it comes to the investigation of a patient who presents with upper GI bleeding, we are going to do generally what my colleague had alluded to during his investigations. However, it is worth noting that endoscopy is the key diagnostic tool in upper GI bleeding. Moving on to the management. Generally, that is exactly how the same way we manage this particular patient is the general approach to a patient who presents. However, in the case where a patient presents with cirrhotic variceal bleeding, that is to say, variceal portal hypertension coming from, being as a result of liver cirrhosis, then we would want to consider giving that patient antibiotics. So prophylactic, so as to avoid bacterial infections in the case of spontaneous bacterial peritonitis. And then there is equally no role of tranexamic acid in the arrest of upper GI bleeding. Okay, so this is a visual representation of an ulcer on endoscopy. So I will move on lastly to the complications of upper GI bleeding. Number one, we have spontaneous bacterial peritonitis. We have hepatic encephalopathy, especially in those patients with a cirrhotic liver. We've got anemia, we've got shock, we've got acute kidney injury, especially because of the hyperperfusion of the kidneys in this patient who is bleeding. To mention but a few, there's many more. So this brings me to the end of our presentation on a case of upper gastrointestinal bleeding patient. Thank you.
Yeah, it's okay.
Dr. Pisa, I wanted to ask on the interpretation of this, my electrolytes. I have potassium to be low and urea to be low and the creatine to be low. So could it be that this is a patient?
How low was potassium?
Madam Shinondo, I'm letting the
2.9.
participants now. We're ready?
And sodium was normal.
And sodium is normal.
So basically was
The vomiting. So due to the vomiting.
yeah.
And also the creatinine or the one I mentioned for the muscle system.
Ms. Shinondo, can you hear me? Okay, I'm letting in the participants now. Then we can start at 05.
Okay.
Good afternoon, everyone, and welcome back to the Lusaka Apex Medical University Virtual Clinical Educational Grand Round. I'm your host, Ms. Shinondo, here as part of Corporate Communications at LAMO, and I will be your host. Today's topic is upper gastrointestinal bleeding. I would like to acknowledge the presence of our professorial team, Professor Njelasani, Professor Lambert, Professor Mudenda, Professor Mwava, Professor Mulenga, Professor Mwansa, Professor Mouse, as well as Professor Gelani, Professor Kumar, Professor Kasonga, as well as Professor Kasoro, to name but a few. The rationale behind these grand rounds are, these are presentations for our students, by our students. These are presentations based on clinical cases that our students in the field during placement encounter. Now, these presentations are for skill set building, skills such as long case presentation, self-presentation, seminar and webinar management, as well as critical thinking. This is where they will take us through their patient case, the rationale behind why they did what they did. And as always, this is an excellent opportunity for them to work on their nerves as well as get used to giving presentations. For most of our students, these are usually one of their first presentations. However, this sets an excellent foundation for them to have future presentations from a strong foundation that we give them here at LAMO. Without any further ado, I would like to invite our moderator, Dr. Mpisa, to briefly introduce the topic and begin the presentation. Dr. Mpisa, the floor is yours.
Thank you so much. Welcome everyone to our playgrounds. Today it's a day we are having Unit 2 from the University Teaching Hospital, which is the GI team, and they are presenting about upper GI bleeding, which is one of the common emergencies. And as a doctor, you should be comfortable managing emergencies and not be afraid. So that's why we train people to manage emergencies. And today we hope after the presentation, everyone will be comfortable to manage the emergency of upper GI bleeding. So please enjoy the presentation of upper GI bleeding. We'll start with the case presentation. Then after that, one of our students will do an overview of the management investigations involved in upper GI bleeding. So without wasting time, I'm now inviting the first speaker to present.
Right, thank you. Good afternoon. My name is Alphonse Fiore, a fifth-year medical student with the Lusaka Apex Medical University. I'll be taking you through the history on a case of upper gastrointestinal bleeding. So this is a case of Mr. GM, a 26-year-old male from Sierra. He's a practicing Christian of the World Apostle denomination. He does occasional farming of maize and is currently not married. The patient, as well as the mother, provided us with the information. This patient was admitted on the 6th of February 2025 and reported his details on the 7th of February 2025. He's a clinical referral from Siavonga Level 1 Hospital for further management of hematemesis and melena. So he came in presenting with the following complaints: vomiting of blood and black stool for a day. In his history of presenting complaints, we found out that this is a known patient to have esophageal varices since 2018, now presenting with vomiting of blood containing clots but no food particles. It is projectile in character and it quantified to fill up an empty bucket of corn soap about 2.5 liters. This patient also reported a black color stool simultaneously occurring with the vomiting, with about 3 to 4 bathroom visits, but denied any episodes of bright colored stool. Bright red color stool. There was associated loss of appetite coupled with weight loss, abdominal distension, abdominal pain, which was epigastric in origin of sudden onset, burning in character, and non-radiating, stated to be about 9/10 in severity, and alleviated by Panadol and water. It did not know the exacerbating factors and denied constipation, difficulty swallowing, and yellowing of eyes. This patient further reported bleeding from the nose, blood clots. There was no mucus, and it took about 30 minutes to stop, and denied bleeding from anywhere such as under the skin or easy bruising. This patient equally reported headaches, palpitations, dizziness, blurred vision, or infatigability, but denied fainting, seizures, chest pains, difficulties in breathing or lying flat, or difficulties in breathing that would make him wake up at night from his sleep. This patient then gave a background of lots of swimming in rivers in his childhood, but not currently. He also denied the issue of alcohol use, smoking, or use of non-steroidal anti-inflammatory drugs. He then reported to Siavonga Level 1 Hospital upon onset of these symptoms, where he was admitted, then referred to the University Teaching Hospital the following day for further management. On his review of systems, the gastrointestinal tract, the cardiovascular system, and central nervous system were as in the history of presenting complaints. There were no coughs, no wheezes, no hemoptysis, or sore throat on the review of his respiratory system. And the musculoskeletal system showed that there were no skin rashes, no joint pains, no joint swelling, and no yellow eyes. His genitourinary tract, there were no frequencies, agencies, or dysuria, neither was there hematuria. Past medical, he has had no history of diabetes, epilepsy, asthma, TB, hypertension, or sickle cell. This is an RRT patient who is reactive since 2005. It has been on ART and compliant. There's been at least two hospital admissions per year since 2018 for a similar presentation. He usually receives blood with every admission, and there's been no history of accidents, no injuries. His drug history includes use of Panadol, omeprazole, propanol, Buscopan, TLD, iron, vitamin C, vitamin B complex supplements, and there's been no non-reaction to these drugs, neither are there any non-food allergies. His family history doesn't include any history of diabetes, epilepsy, asthma, TB, hypertension, neither is there sickle cell. But there is a history of esophageal varices with hematemesis and melena, occurring in his elder sister since 2014. Socially, he doesn't take any alcohol, he doesn't smoke. He's an occasional farmer of maize and drinks tap water, which is chlorinated. The toilet is a flushing system, and he lives in a four-roomed house with 9 other occupants. In summary, I'm presenting GM, a 26-year-old male who is RRV directive, a patient known to have esophageal varices since 2018, now presenting with hematemesis, melena, and epistaxis for a day, with symptoms of anemia, epigastric pain, abdominal distension in a non-alcoholic, non-smoker patient with a background of fresh water exposure with no history of non-steroidal anti-inflammatory drug use. The impression was a 26-year-old male with upper gastrointestinal bleeding, complicated by symptomatic anemia, secondary to esophageal varices, secondary to portal hypertension, due to his history of being exposed to rivers, which could have led to a pathology that can increase which can cause portal hypertension, leading to esophageal varices, where we see him vomiting blood and melena. Our first differential was peptic ulcer disease because of the symptomatology of the presenting of the patient, where he is experiencing gastric pain and the vomiting of blood with the melena. Then the other one is symptomatic thrombocytopenia due to the portal hypertension, which can predispose to the nosebleeds, which we see in his complaints, in the history of his complaints. I will now hand over to my colleague who will take you through the examination. Thank you.
Good afternoon, everyone. My name is Timothy Shimoka. I'm a fifth year medical student at Lusaka Apex Medical University. I will be taking you through our examination. So on general examination, I examined a young adult who was propped up in bed, ill looking, but not in any obvious respiratory distress. He was well oriented to time, place, and person. He had a left nasal packing, a green cannula in situ on the left forearm. He was of fair nutritional status, but was pale. He had flank fullness and was febrile. His vitals were the BP was 105/60, which was slightly low, but this could be attributed to the blood loss. So there was hemodynamic instability, and also he was on propanol. Then the pulse was 50 beats per minute, which was also low, but remember he's on propanol. Then the temperature was 36.7 degrees, which is normal. respiratory rate 18, breaths per minute normal, and oxygen saturation was 98, which is normal as well. So on closer examination, on the hand, our patient presented with palmar pallor. He had finger clubbing grade 1, but then there was absence of leukonychia, cheilonychia, palmar erythema, reductions contracture, and asterexis. So his capillary refill time was delayed. His pulse was regular, full volume. There was radiosynchrony. It was at 52 beats per minute. The patient also had axillary hair. Then on the face, there was conjunctival pallor. Then there was atrophic glossitis. Then there was absence of jaundice. There was no angular stomatitis. There was no beefy time, and there was no parotid enlargement. And then on the neck, there was no jugular vein dissection. Then there was no lymphadenopathy. On the respiratory system, the trachea was centrally located. The patient had traditional markings around the left nip, but then there were no surgical scars, there were no tattoos, no spider nevus, and no gynecomastia. Our patient presented with an enlarged right nip. Then there was echo chest expansion, there was echo air entry on both lungs, then vesicular breath sounds were heard. Then on the cardiovascular system, the apex beat was palpated on the fifth intercostal space, mid-clavicular line. S1 and S2 sounds were heard. They were regular, though bradycardic at 52 beats per minute. And then there were no added sounds. Then per abdomen. So the abdomen is normal hair distribution. Abdomen was moving with respiration. There were no scars, no tattoos, no caput medis. The abdomen was soft. It was tender on the left, upper and lower quadrants. There was no guarding, there was no rebound tenderness. The patient presented with splenomegaly, but no hepatomegaly, and there were no any other palpable abdominal masses. There was the negative fluid flow, but then there was positive shifting downwards. Bowel sounds were heard. They were normal at 3 per minute. Then digital rectal exam. So anal hair was seen, no external hemorrhage was seen. The anal sphincter tone was normal. There was no tenderness. Then fecal matter was felt. It was soft. Then the posterior wall was smooth and there were no masses. Then anteriorly, the prostate was palpated. It was of normal size. Then it was firm. Then it was firm with a palpable median sulcus. Then there was no melena on the globes. Musculoskeletal system. There was no pedal edema, no joint swelling, no joint tenderness. There was no petechiae. There was no ecchymosis. So on summary, I'm presenting a young male adult. Examined a young male adult propped up in bed with left nasal packing, with palmar pallor, finger clapping, conjunctival pallor, atrophic glossitis, splenomegaly, ascites with bradycardia, but no jaundice, no asterexis, no petechiae, no ecchymosis. Our impression was upper gastrointestinal bleeding complicated by symptomatic anemia secondary to esophageal varices, secondary to portal hypertension. Our thinking being, in the examination, we found that there was palmar and conjunctival pallor. So this hence justifying our reasoning saying he is anemia, he's anemic, sorry. And then the esophageal varices being justified by the portal hypertension. So we said he had portal hypertension because there were signs of portal hypertension, which included the ascites and the splenomegaly. That's how we came out with our impression. So I'll leave the investigations for my colleague.
Good afternoon. My name is Kelvin Stenge, a 7th year medical student at Lusaka Apex Medical University, and I'll be leading you through the investigations. The investigations, we are going to look at diagnostic and supportive investigations. I would want to say that the only results that we have that were read by then, we only have the full blood count and the upper GI endoscopy. The rest of the results were not yet read by then. So the ordered investigations for diagnostic we have got gastroduodenoscopy, which is the upper GI endoscopy. This one is going to help us confirm the presence of the varices and also rule out the ulcers, which are gastric, and also duodenal ulcers. When you look at the patient did not cooperate for the previous for the recent results on the upper GI endoscopy. However, we have the results that were done 2 years ago that confirmed the presence of varices. You can see on the right paper, those are results for endoscopy. However, for the supportive, would want to cross-match the patient. This is a patient who comes with bleeding. Would want to prepare him for blood transfusion, and also would want to do the LFTs or the liver function test to assess if there is any possible liver pathology or cirrhosis that could have led to the portal hypertension and leading to varices. However, we're also going to order the electrolytes and urea and creatinine. I'll show you this. We have the results on the next page. So here, as you can see, I'll start with the electrolytes on top. We are seeing that the patient is having low potassium, urea, and creatinine. This could be because this is a patient who was vomiting and could have lost some electrolytes through vomiting and also some diarrhea that he had. On the creatinine, this is a patient also in the history who had said he has got loss of weight. So this is because of loss of muscle mass that could have led to the low creatinine. We're also going to do the liver function test, and you can see from the liver function test we are the only results here that are low. We have got total protein and albumin, which is low, and also aspartate transaminase is high. Now this is when you look at the aspartate transaminase to be high and the alanine transaminase to be low, it's showing that now here this is not actually a liver problem because AST can be also released from the other breakdown of muscles from the body. In this case, this is a patient whom we may think could have been starving because he had said he has got some pain when swallowing, so it did not. There could be some breakdown of the muscles. So no wonder we are saying that the AST it is high to provide the protein, and we are seeing the total protein is low there, which is also showing that it could be due to the malnutrition or having that deficiencies of protein. Then also we are going to do the full blood count and the platelets. You can see down there, it is showing the white blood cell and all other, apart from them, still to below. This is actually showing a pancytopenia. This is a picture of pancytopenia with severe thrombocytopenia of 8. So putting the patient at high risk of bleeding. And we are also going to do, and go back, we are also going to do the stool and urine microscopy. In this one, we would want to we would want to look for the schistosoma eggs. In this case, this is a patient with a history of a background in childhood playing in freshwater bodies. So when we do the stool and urine microscopy, find that the test is negative for the eggs. We would want to do the serology test to show if there was any previous infection. Then we'd want also to do the CD4 count and viral load. This is a patient who is a RVDR patient. So we want to assess for the state of the immunity, and also would want to appropriately manage the patient and prevent other possible complications. We want also to do the hepatitis B and C serology or profile, where we want to rule out the other core possible infection in this HIV positive that could affect the liver and bring other GI complications. I think for now, I'll also hand in to my colleague who take you into management.
Okay, so good afternoon, everyone. My name is Netisile Nkambule, a seventh-year medical student from the Lusaka Apex Medical University. And I am going to take you through the management of this particular patient who presented with upper gastrointestinal bleeding. So upper gastrointestinal bleeding is a medical emergency. So the first thing that we are going to do upon arrival with this patient is call for help. We are then going to do a quick assessment of this patient using the ABC approach. Under A, which is the airway, we just need to make sure that there is a patent airway. Under B, which is breathing, we are going to run this particular patient on 100% oxygen via nasal prongs at 3 liters per hour. Under circulation, we are going to monitor the patient's pulse, then quickly insert 2 large bore cannulae and run the patient on IV fluids so as to stabilize the hemodynamic status of this patient, as well as stabilize the BPs, which were already low. We are then going to urgently transfuse this patient while we await the cross-matched blood. Ideally, we are going to give O negative blood. Then we are going to give IV proton pump inhibitors, omeprazole 80 milligrams IV stat, then an infusion of 8 milligrams per hour for 72 hours, then switch to oral 40 milligrams BD. So the reason why we want to give proton pump inhibitors in this patient is because one, we want to neutralize the gastric acidity, but then secondly, we want to prevent, PPIs prevent clot lysis. So if you are inhibiting clot lysis, then it means we are going to stabilize the clots that are in the gastric tract, hence limiting the amount of bleeding. It is very important that we do give proton pump inhibitors before we do the key diagnostic tool that my colleague had already mentioned, the endoscopy. So as to avoid a situation where this is a patient, yes, with esophageal varices, but we might incidentally find peptic ulcers which may bleed in contact. Then we are going to this is a case of like it's a medical emergency. So we can insert a blood pneumo tube, which is going to exert pressure on the varices, hence acutely or urgently arresting the bleeding while we await the definitive management, which is standing. We are then going to give telepressin, 2 milligrams IV stat, then 4 hourly, or octreotide, 100 micrograms subcutaneously TDS. These two drugs work in a similar way. So this is a patient who has got portal hypertension as evidenced on examination with the ascites and the splenomegaly. So these two drugs are going to cause splanchnic vasoconstriction, which is then going to limit the amount of blood that goes to the portal vein and lower the portal hypertension. We are then going to transfuse this patient once the cross-matched blood arrives, ideally whole blood, and we are going to do a restricted blood transfusion. What then do I mean by that? We know that this is a patient who presented with a hemoglobin of 2.5 milligrams per deciliter, in as much as on the investigations it was at 5 because the patient had already received some blood at the time. So we will know that, then we are going to aim for a hemoglobin of about 8, which is still way less than the normal. The reason why we want to limit to an average of about 8 milligrams per deciliter is because we want to avoid a situation where we overly give blood to this patient, which is then going to worsen the portal hypertension and further decompensating this patient through bleeding. We could consider platelet transfusion because of the patient who presented with a severe thrombocytopenia of 8. We will know the normal range is about 145 to 400. This was evidenced by the epistaxis or the nosebleed in this patient. We are then going to closely monitor the vitals of this patient who is hemodynamically unstable. Then, outside of the acute phase, we would consider giving, or we will give propranolol. So however, this is a patient on the drug history who is already on propranolol. So what we are going to do in this acute phase of bleeding, we are going to stop the propranolol, then only give after the acute phase of bleeding. Why? Because this is a patient who has presented with massive bleeding. And one of the ways that the body tries to compensate for the blood loss is increasing the heart rate. Right. So if we are going to give propranolol to this patient, it's going to slow down the heart rate, which is meant to compensate for the patient's blood loss, and it will further decompensate the patient. I had already previously mentioned to say in the case of an emergency bleeding where we don't have an emergency banding service, we can insert a blood sense taken tube, which is going to exert pressure on the varices and stop the bleeding. But the definitive management is banding. So banding is basically putting rubber bands around the varices, which is going to collapse them, so they will thrombolize and collapse. We are then going to look out for other complications of the upper GI bleeding, such as your spontaneous bacterial peritonitis, AKI, anemia, shock, to mention but a few. Then we are going to cancel the patient on compliance, especially the propranolol part of it, because this is a patient who's got portal hypertension, and we need to make sure that the patient has low portal hypertension values. So this is a visual representation of the black mosaic since taken tube, and that I was previously talking about, that is going to urge you to stop the bleeding on your left. And then onto your to your right is an endoscopic finding or an endoscopic visualization of the esophagus with some banding. With some banding, I'm sure you can be able to see that we are equally able to visualize the dilated tortuous veins on the esophagus. All right, so I am quickly going to give you a short overview of upper GI bleeding. What then is upper GI bleeding? So upper GI bleeding is bleeding in the gastrointestinal tract, proximal to the ligaments of Treves. The ligament of Treves is located at the junction of the duodenum and jejunum. Hematemesis is vomit out of blood, which may be fresh or like coffee ground material. Melena, blood turrets or stools due to bleeding in the upper gastrointestinal tract. Some of the causes of upper GI bleeding in Zambia include 1, esophageal varices, number 2, peptic ulcer disease. These are the top 2 commonest causes of upper GI bleeding in our setup here in Zambia. But some of the other causes of upper GI bleeding in our setup are esophagitis, such as a reflux esophagitis, for example, in the case of gastroesophageal reflux disease. We could also have esophageal carcinoma. We could have gastric carcinoma. We could have Mallory raised here, which is basically and like the irritation of the mucosa in the lower esophagus. Then we could also have carpocytoma as one of the other causes. So some of the other clinical features of upper GI bleeding are hematemesis, melena, abdominal pain, tachycardia, fatigue, loss of consciousness, fainting, dizziness, shortness of breath, loss of appetite, to mention but a few.
Apologies for the interruption. We're currently having brief technical difficulty. But once again, don't forget, this is the Lusaka Apex Medical University Virtual Clinical Educational Grand Round. These happen every Thursdays, comprised of 5th and 7th year medical students. Once the presentation is over, there will be a question and answer session. So please have your questions ready. You can also share any observations and the like. Also take note that you can either ask your questions by raising your hand, the floor will be given to you, or you can write your questions in the chat and they will be read out for you. Presenters team, are we doing okay? Not yet, but they will be back online. Why do we have these presentations? Once again, these are capacity building within our students. Long case presentation, soft presentation, as well as being able to walk us through their critical thinking, their reasoning, their rationale, and the like. In the meantime, please be aware that we're currently enrolling for our January intake. However, extended registration is almost over. For those who aren't aware of some of the programs we offer, in the meantime, please let us share this advert just to give you an idea. Now we're back. Welcome back, presenters.
I think that's where I was when we were interacting. So some of the clinical features are hematemesis, melena, abdominal pain, fatigue, tachycardia, dizziness, fainting or loss of consciousness, shortness of breath, and loss of appetite, to mention by a few. All right. So when it comes to the investigations, my colleague gave a general overview or a general approach to investigating patients with upper respiratory. However, it is worth noting or worth mentioning that endoscopy remains the key diagnostic tool in upper gastrointestinal bleeding. When it comes to the management, I gave the management in as much as we were managing this particular patient. However, it still remains the general approach to patients who present with upper gastrointestinal bleeding. However, in patients who present with cirrhotic variceal bleeding, that is to say, portal hypertension coming as a result of liver cirrhosis, may benefit from antibiotics so as a prophylaxis to bacterial infections such as spontaneous bacterial peritonitis. This particular esophageal viruses might have not been cirrhotic, but it might have attributed to the exposure to freshwater bodies and schistosomiasis exposure. There is no role of tranexamic acid in upper gastrointestinal. So this is a visual representation of how ulcers, gastric ulcers look on endoscopy. So moving on, lastly, to the complications of upper gastrointestinal bleeding. One, we've got spontaneous bacterial peritonitis. We've got hepatic encephalopathy, which mainly come as a result of liver cirrhosis. We've got anemia, we've got shock, and we've got AKI, which may come as a result of hypoperfusion of the kidneys. So this brings me to the end of our presentation on a case of upper gastrointestinal bleeding in Mr. GM. Thank you.
Excellent. Well done, presenters team. Dr. Mpisa, do you have any summary to give this presentation before we move on to question and answer?
Thank you so much for the presentation, More than yeah, so that's what we do in Unit 2 in IMEC. We train them to be confident to present patients they see every day. This is their work, as we are just there to guide them. So yes, upper-GI bleeding is very common, and this is a typical example of a non-cirrhotic portal hypertension patient coming from Siavonga. They are exposed to water bodies. They get schistosomiasis. Usually it's in their childhood. That's why, like the presenter said, when we test now, we won't find the evidence of schistosomiasis because this is now it's long gone. It's just the sequela, which is now the portal hypertension. So I think they did very well with the presentation. Apogee bleeding is very common. I just want to comment on the management that yes, this is a patient we already knew that it varices, but like the presenter said that the commonest cause in our setup is varices and peptic ulcer. So we don't have the luxury of getting an upper GI endoscope as soon as possible. At times, our patients have to wait for 24 hours if they are lucky. At times, they might wait for even a week. So, with that in mind, we always put our patients on IV intravenous proton pump inhibitors so that we manage the common cause, which is also peptic ulcer disease. Even if you know that this patient has varices, we still have to cover for the possible common cause. The explanation was, I think it was clear that proton pump inhibitors, they inhibit the acid production so that we neutralize the acidity. As we all know, if you are bleeding, the first thing you need is to form a clot to stop the bleeding. But you can't form a clot in the stomach when the acid is, the pH in the stomach is around 1.5. You can't do that. So that's why intravenous proton pump inhibitors are very important. Also, the role of antibiotics, she rightly said that if a patient has liver cirrhosis and they get upper GI bleeding, those are the patients who usually decompensate. They start getting hepatic encephalopathy, they get spontaneous bacterial peritonitis, hepatorenal syndrome. So those ones, they will need antibiotics on top of the other management which has been mentioned. So I can just say, all done, team. We are now wait and we are ready for the questions. Thank you.
Sure.
Excellent. Thank you. Thank you, Dr. Mpisa. Now, question and answer session is open. Once again, you can either ask your question by writing it in the chat and it will be read out for you, of which our presenters will answer accordingly, or you can raise your hand. The floor will be given to you. We have our first question from Dr. Mills. Was a bedside clotting time done? Do you think it's significant to the diagnosis and management of this patient?
We did not do the bedside time. However, it is significant to the management because in a case where it takes long, for instance, the clotting time takes you more than 13 seconds after you draw the blood from the vein. It shows that the patient has got problems with the clotting system or clotting cascade. So that was an oversight. Otherwise, it's very much important. We were supposed to do that as we were seeing the patient.
Okay, thank you. We have a two-step question from Chipo Nandu. Why did the examiner do a rectal exam, which had a response about it being a full gastrointestinal examination? They followed it up with, what was he checking for? So to our presenters, what was being investigated?
So number one, it can never be a full gastrointestinal tract examination without a digital rectal exam. However, what we were looking out for in this patient with the DRE was one, the evidence of melena. This is a patient who presented to have said in the history they had blood stool. As a clinician, you need to confirm the presence of melena in using the digital rectal exam. However, we could equally pick up other possible causes of the GI bleeding and possibly check out for other possible causes or a possible presence of a lower gastrointestinal bleeding. Thank you.
Thank you. We have one from Shamgar Mwasha. First of all, this is an amazing presentation. My question goes to Dr. Dube, and I stand to be corrected in case I didn't get you correctly. In your HPC, you mentioned alcohol smoking and NSAIDs use, but in your summary, they appeared as important negatives. Did the patient stop? And if he was exposed, what's the duration?
Thank you for the question. I might have maybe misspoken, but the patient denied any use. He denied any use of alcohol, smoking, and non-steroidal anti-inflammatory drugs. Maybe I might have been inaudible on that. He denied any use of them at any point.
All right. So the second part of the question was why did we put them as important negatives? So this is a patient we had already mentioned to say The two most common causes of upper gastrointestinal bleeding in Zambia is PUD and esophageal varices. In as much as yes, we already know to say this is a patient known to have had esophageal varices. However, we still needed to look out for symptomatology for PUD. The patient did have epigastric pain. The patient did have melena and hematemesis. However, we then needed to exclude other possible causes of peptic ulcer disease, which is alcoholism, which is which is smoking as well, and the NSAID use. Thank you.
Thank you. We have a comment from Chola Bertha. Says great presentation. A round of applause to you. We have one from Victoria Malindi. Thank you for the presentation. As you manage the patient, you want to look for signs of complications. What investigation would you do to look out for SPB, or rather SBP?
To look out for spontaneous bacterial peritonitis, we are going to look out for under the blood investigations. We'll look out for the bacterial infections. If there's any elevation in the back, if there's any increase, especially neutrophils, if there's any increase in the white cell count, any rise in white cell count, and also in line with on physical exam with temperature, we are going to suspect that the patient actually has got SPB. And also they'll present with a tender abdomen. Yeah.
All right, so in addition with what Dr. Kelvin has already mentioned, we equally want to do a paracentesis where we insert a needle and aspirate and take the sample for culture. Thank you.
Thank you. We have one more from Shamgar again. This is a patient who has been on antiretroviral therapy since 2005. In the case of low CD4 count and high VL, would that have changed your management? If yes, how?
All right. May I give the floor to our moderator, Dr. Lisa? Okay, please kindly repeat the question.
Oh, so can I get the question again? I can't.
This is a patient who has been on ART since 2005. In the case of low CD4 count and high VL, would that have changed your management? If yes, how?
Oh, thank you so much for that question. Yes, so if the patient is low viral load, there's a low CD4 in the high viral load, which means they are fading. So on top of the upper GI bleeding, we should manage their HIV also. So this is a patient, if the CD4 is low, you will suspect that even the risk of getting infections is high. The previous question was on spontaneous bacterial peritonitis. The risk will be higher for infections. So the change will be one is on TLD, which is the first line. So if someone is on the first line treatment and they get a CD4, which is low, and the viral load, which is high, so they both virological and immunological failure, which means we need to switch them to a regimen which works. So we might need to switch them to a second line treatment. Thank you.
Thank you. All right, we have another question from Dr. Mikoki. Great presentation. Love the detail. Considering your first differential was peptic ulcer disease, It would have been nice to bring out the typical pain symptoms associated with meals in your history. Also adding H. pylori could be, forgive me, could be tolerated in your investigations, preferably stool. If this is not clear, Dr. Mikabe, could you please offer some guidance on this? However, presenters team, is it clear for you?
Yeah, thank you for the question. Yeah, I think it's a valid point that whenever someone vomits blood, the issue of peptic ulcer disease, the questions around the pain, they should be put out. I think the presenters tried the question also on H. pylori is true, H. pylori, investigating it. Yes, I think I agree with the question that it should be part of the investigations because H. pylori is quite a common cause. Though, since we are already doing an endoscopy, we can actually do the invasive test which confirm H. pylori. When you do an endoscopy, you see an ulcer, you can do a rapid urine test on that ulcer, you get your quick diagnosis of H. pylori. So I agree with the question that H. pylori should be investigated in every upper GI. Thank you.
Thank you. So once again, the floor is open. Please, you have to accept my apologies for the noise in the background. I'm currently not in my office, but rambling never stops. So, please feel free to ask more questions either in the chat or you can raise your hand. The floor will be given to you. This is not only a learning opportunity for our presenters, but it's also a chance for you, those in attendance, to get comfortable with online sessions. This is you getting comfortable, learning how to ask questions as well as webinar etiquette. So please, as much as this is a learning opportunity and a learning curve for our presenters, it is equally a learning curve for yourselves as attendees. So please take full advantage of this platform. Please bear in mind, if people do not ask questions, I will call names. We have one from Judith. Thank you. Would a bleeding disorder be a plausible differential?
Yes, a bleeding disorder could be a differential, but not specifically in this particular patient. I am assuming you're asking because of the epistaxis and the thrombocytopenia in this patient. However, in the history, we tried to rule out any other symptoms of coagulopathies. Even on examination, we tried to rule them out. So the cause of thrombocytopenia in this patient is probably due to the portal hypertension. We will know the anatomy of the portal vein with the superior mesenteric artery and the splenic vein. So if there's going to be pressure on the splenic vein, then we are predisposing the patient to splenic sequestration, hence the thrombocytopenia or pancytopenia. Thank you.
Great, thank you. Well done. We have another one from Chola Bertha. How would you manage such a patient if they had a coexisting condition for which they are taking anticoagulants?
Okay, so I will direct that question to Dr. Mesa.
Thank you for that question. Yeah, that's why we always So remember, referral is part of management, right? Even when you guys qualify, just know that there are limits to my practice. If I refer a patient accordingly to someone senior, to someone who is more specialized, I would have done better for that patient. So then that patient should not be really managed at a facility where there are no specialists. So if the patient is on anticoagulants, it depends on which anticoagulants, like you say, and it depends also on the indication of the anticoagulants. So we always say bleeding is more forgiving than thrombosis. Most of the times, patients with anticoagulants, they have a thrombus somewhere. Someone has a massive pulmonary embolism and they are bleeding. It's better they continue the anticoagulant so that the pulmonary embolism does not continue to progress, whilst we try to arrest the bleeding. So we usually favor the side of anticoagulation to continue them if the indication is life-threatening. If a patient is maybe is on anticoagulants, maybe let's say on antiplatelet therapy for stents, there are patients with myocardial infarction, they are on dual antiplatelet therapy, they come vomiting blood. What are you going to do? So this is a multidisciplinary approach. Like I said, you can't do everything alone. We discuss with the cardiologist, discuss with the gastroenterologist, what the best way should we do. So usually, if someone is on dual antiplatelet, we stop one of those antiplatelets and we continue the aspirin. We stop three-phenobarbital, we continue the aspirin. Then we then manage the GI bleeding. Then also we can put clips, then stop the bleeding. If varices, you do the banding and transfuse. Once that's stopped, that's sorted, then the patient goes to their dual antiplatelet therapy. If they are on warfarin, you can give the reversals. I think you all know the reversal for warfarin. The antidote, we usually give vitamin K. For heparin, it's protamine sulfate. So it's a case by case management. But thank you for that question. It's a multidisciplinary approach. That's what I can just say.
Thank you. Please take note, the floor is still open for questions, contributions, as well as observations. I would also like to appreciate some of the members of the audience. You have been consistent attendees of these grand rounds, of which I would like to say thank you. Do we have any other questions or observations? I see we have Professor Mulenga with us. Professor, are you available to comment?
Not at the moment. Thank you.
Thank you. Okay. We will take one more question. In cases where IVs are not available, what management can you advise while waiting for endoscopy?
So on the place where we don't have IVPVIs, we do have we do have oral PPIs in our setup. It's oral protein pump inhibitors are readily available. That's what I can do. Thank you.
Excellent. Thank you. So question and answer session has now come to a close. I would now like to invite closing remarks, starting with our presenters team. Presenters, the floor is yours.
Good afternoon. First and foremost, we would like to extend
Please give us a moment. I see we have with us Professor Mwawa, our CEO. Welcome, Professor.
Yes, I've been around and I've enjoyed the presentation. I think I would just like to thank the moderator and the team for putting up such a good show. And just to mention that bleeding patients are medical emergencies and they require a mouth, meaning that among the things that are key is to make sure that you inform the surgeon, you inform other people, hematologists and everybody else, so that you see all the corners. I think it's critical that you have a multidisciplinary team and people on standby to come and help you. You cannot manage these bleeding patients alone. Anyone who is bleeding and bleeding badly, you need a multidisciplinary team. I think that's the most important. But this is a job well done, and I'm very proud of the team and the job that they have done. Thank you.
Thank you, Professor. Thank you so much. I would like to once again invite our presenters team to give their closing remarks.
Thank you very much. First and foremost, would like to extend our deepest gratitude to the professorial team for your invaluable feedback and guidance during today's presentation. This has been a valuable learning experience in that your insightful observations not only challenged us, but also encouraged us to think more deeply about clinical decision making, differential diagnosis, and also patient care. Therefore, we are privileged to have had this opportunity as a team to engage with you today. We look forward to applying the lessons learned today, to put them into our practice even as we become health practitioners. Would also like to give a special vote of thanks to our moderator, Dr. Bisa. Throughout our presentation for this case, you have been a constant source of guidance, encouragement, and constructive feedback. Your dedication to ensuring we were well prepared and confident in our clinical reasoning has made a huge difference even in the presentation today, as affirmed by our professor, who is pleased with the way we presented. We are deeply grateful for your time and effort. To my team of fellow presenters, I would like to take this opportunity to express my heartfelt thanks. Throughout our preparation, each of you demonstrated teamwork and a genuine commitment to learning. Our collaborative spirit and willingness to share ideas made this experience not only productive, but also enjoyable. We would like to thank our audience for your attention and engagement throughout our presentation. You have helped enhance our learning experience. Certain things that we might have forgotten in presenting, we have brought them to discussion, which shows that we are teaching each other, and we are, at the end of the day, we are learning something from both teams. To my fellow students, my team and I stood here for the first time, by the way, and while it was both some kind of nerve wracking and exciting, it was also deeply rewarding. We have learned that a presentation like this are not actually about perfection, but about growth, collaboration, and building confidence among us as students, helping us become competent healthcare providers. We encourage each one of you to embrace every opportunity to step up and present. It's a chance to learn not just from our mentors, but also from one another. And I truly believe that every experience makes us a better clinicians. And finally, to the organizers, Ms. Nondo and the IT team, thank you for all your coordination and support behind the scenes. Your dedication to make sure we were prepared and organized gave us the confidence we needed for today's presentation. To the IT team, thank you for managing the technical setups and ensuring everything ran smoothly. Thank you very much.
Well done. Well done. I would now like to invite closing remarks from our moderator, Dr. Mbisa.
Thank you everyone for joining us. I hope you enjoyed and I hope you learned Yeah, aperture bleeding, it's what we do every day, and we, like from our side, it's teamwork. You can't do everything alone. You need help from all the other colleagues. So my closing remark is being a doctor is not always a smart job. You need to be dirty at times. I think I got a question from the chat. Someone asked why we did a DRE. I always joke with students in the world that the only reason why we don't do a DRE digital rectal exam is when your index finger is missing. So please learn to do digital rectal exam in all patients when you are doing a GI exam. Thank you.
Thank you, Dr. I would like to invite any of the members of our professorial team to give their closing remarks.
Once again, good afternoon, everybody. I think, like it has been mentioned, this was a worth it exercise given by our students. And also, thanks goes to the moderator, who I noticed that was being thrown with some questions from the students, which we expect that the students should first of all make an attempt to answer the question, and then you get a refinement from the moderator. That's how you learn and even correct your mistakes. Good advice has also come from Professor Mwaba, who's very experienced in that teamwork is very, very important in the cases of managing your patients. And as a university student, what also differentiates us from others is that we must have an inquisitive mind to do a bit more of research and do some organized research. That means even when you do a literature review the global issues, come to the region, come to your country, and then the place where you work, where you're going to work. That way you serve your people better when you have that inquisitive mind. And also know the type of people who are presenting with such kind of a problem so that you, in your mind, you can begin to form a pattern. But on the whole, thank you very much for a well-prepared work. We know that in the background, some of you are not even sleeping, but you've gotten a very good display. And of course, we want to thank all the seniors who've actually attended this session. And of course, the students who have listened in. This is their program. Students have been there from various locations. This is a worthwhile exercise. And also, Madam Shinondo for putting up good work, and the IT group in the background. It's not easy. Thank you very much, everybody, and go well. Thank you.
Thank you. Thank you so much, Malanga. We have come to the end of today's virtual clinical educational grand round. Today's topic, upper gastrointestinal bleeding. I hope you all enjoyed this. Once again, well done, presenters team. You've done exceptionally well. Please continue setting the bar higher and higher. Now, just a brief reminder that Mondays through Thursdays, we have presentations. Mondays are pre-medical, Tuesdays are preclinical, Wednesdays are research, and Thursdays are the grand rounds. These are long case presentations from our students' ward rounds. So please look out for further communications on all the respective days. Well done, team. Thank you, professorial team. And I would also like to thank those in attendance who stuck around, and especially those who participated. We have come to the end. Thank you. Enjoy the rest of your day.